Okay.
So today we'll discuss
Previously,
congenital. Huh?
congenital rheumatic heart disease.
Okay. Thank you.
We have discussed rheumatic heart disease. Now today we'll discuss the rheumatic valvular disease or valvular heart disease. It may be related with the rheumatic or non-rheumatic. So, the common valvular heart disease, the most important is mitral stenosis. Mitral stenosis, most common is due to rheumatic heart disease. Second is mitral regurgitation. It may be due to mitral valve prolapse or rheumatic heart disease or papillary muscle dysfunction. It may be due to endocarditis or it may be due to left ventricular dilatation due to any cause. So mitral regurgitation, mitral stenosis. Now, before that, we discuss a typical case. One patient comes with hoarseness of voice. Hoarseness of voice. So, to consult with a ENT specialist, he gives some antibiotics, some anti-inflammatory, and after 7 days, there is no recovery of that. Patient have already taking some drugs like Digitalis, Lasix, and Panidure in repeated every month interval. So he again visited with the ENT surgeon, but no effect. Then he visited with surgeon. Surgeon, they told me that you must consult with a physician. They perform this thyroid function test, indirect laryngoscopy. So indirect laryngoscopy, there is no visible, clear-cut, obvious abnormality there. So we perform. Did consult with the physician. So she come with me and I perform this 2D echoes and this chest X-ray. So in chest X-ray, there is a typical double contour of the right border of the heart. So double contour of the heart may be due to left atrial enlargement. So there is double contour of the heart. And when I ask the patient that if there are any other complaint of your chest pain, so she said that sometime in the cough, repeated cough, there may be some hemoptysis, blood coming out from the sputum. So I again ask patient to visit a cardiologist, but she said that I have no money to visit the cardiologist. You just treat the patient. So I again started the patient treatment with all these things, and we give patient also suffering from bipedal edema. Bipedal edema. So I give him some medicine like anti-inflammatory, antibiotic, and we gave some bronchodilator, and some neurotropic vitamins, gabapentin, norepinephrine, all these things. So after 7 days, patient come that slightly improved on this hoarseness voice, and then we come to that the patient may suffer from this Ortner syndrome. Ortner syndrome means nothing, but it is the cardiovocal syndrome. The vocal cord is involvement due to cardiac involvement. So this is hoarseness of voice due to recurrent laryngeal nerve involvement, recurrent laryngeal compression due to this left atrial enlargement. So yes, so the rotation, the left atrium rotate introlaterally. So this is the case. And after 1 month of giving all these things with compensated heart, patient improved. Only 10% left with the hoarseness voice. So this is the typical case. One may be the hemoptysis, that is the hoarseness of voice, and patient may come with different faculty, but you must think about the rheumatic, the complication of mitral stenosis. So let us come with the discussion. So initially asymptomatic for 1 to 10 years of condition. Mitral stenosis in the initial stage, there may be no decompensation. Later, the symptoms of heart failure develop, like dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, or there may be hemoptysis. In clinical finding, we see the opening snap after second sound, and rumbling, late diastolic murmur, best heart at the apex. And it is based in by this left lateral position, and patient is asked to take expired and then breath hold. So after expiration. So there may be loud heart sound, possibly peripheral edema, or there may be hepatomegaly. So these are the symptoms of decompensated mitral stenosis. Now, is chest X-ray again, there is right ventricular hypertrophy, and there may be double contour of side of heart due to left atrial enlargement. There may be mitral valve calcification. So this is also important. In echocardiogram, there is diminished mobility of mitral valve. Again, I say that there is Ortner syndrome, so recurrent laryngeal nerve involvement leading to hoarseness of voice. And one condition you may see in congenital heart disease, Lutem-Becker syndrome. It is mitral stenosis associated with second-term type of second-term ASD, which left to right shunt. Okay, so these are the in nutshell simple symptoms of mitral stenosis, and the treatment are the same. You give diuretics to reduce periphery load. You give some antiarrhythmic drugs and anticholinergic if atrial fibrillation develop. Anticoagulant you give some. If advanced, there may be valvotomy or there may be valve replacement. So this mitral stenosis is very common and mostly due to rheumatic heart disease. Now, it may be associated with mitral regurgitation. So mitral regurgitation also due to rheumatic, due to MVP or papillary muscle dysfunction. So in long term, there may be asymptomatic period. It is a chronic condition, MR. When severe or acute, present heart failure symptoms like dyspnea, paroxysmal nocturnal dyspnea, all these things. So when severe acute, there may be. Important is that there is a hollow systolic murmur. Hollow systolic murmur is high pitched. This mitral stenosis is low pitched. So we give in the bell of the stethoscope, but this is high pitched. So diaphragm of the stethoscope, you see the diaphragm of the stethoscope, and blowing murmur radiating from apex to axilla. Apex to axilla or back of the chest. So this is very loud, hollow systolic murmur. There may be chest X-ray, left ventricular hypertrophy, and left atrial enlargement. Echo also determine the MR. So this is the thing. And thus treatment is the same line, anticoagulant, vasodilator. If acute MR, then surgery is required. For chronic MR, replace when the symptomatic or whenever there is some severe symptom. So these are the two conditions we usually come across in day-to-day practice. Second is aortic stenosis. Aortic stenosis, due to congenital heart disease. First, due to congenital heart disease. Second is rheumatic heart disease. So congenital heart disease, rheumatic heart. So there is stenosis. So left ventricle have to work more to pass the blood from the left ventricle to aorta. So there may be symptoms of heart failure, exertional angina, dizziness, and syncope. There is crescendo, decrescendo, ejection systolic murmur radiating to carotid, there, right carotid murmur, decreased with Valsalva maneuver. There may be ejection click. Second sound is very weak, and the pulse is pulsus parvus et tardus. That is small and slow carotid upstroke. So pulsus parvus et tardus due to aortic stenosis. Chest X-ray may show calcified valve, and echo may be some lesion in the valve, aortic valve. So this is aortic stenosis. So patient may come with syncopal attack. Nothing complication like this chest pain or this may come with only syncope. So there are different causes of syncope. So one of the cause is that aortic stenosis. So you must take your mind that aortic stenosis, in case of syncope, you must auscultate your heart. You see the other condition of the aortic stenosis. So treatment is avoid over diuresis. Diuresis नहीं देना ज़्यादा. Avoid vasodilator. Vasodilator नहीं देंगे like nitrate as emitter. Beta blocker help करता है to reduce cardiac workload. So beta blocker हम लोग देंगे and valve replacement is the last choice. ER. ER is very funny, this regurgitation. Previously, it was due to tertiary syphilis, but nowadays syphilis is not so important. So there may be aortic root dilatation, dissection of the aortic, aorta, rheumatic heart disease, congenital heart disease, or some genetic condition like Marfan syndrome, you get aortic regurgitation. Usually it is also asymptomatic until advanced cases and then present with heart failure. So all the cases of what this valvular region fed ultimately is heart failure. So patient comes with breathlessness, exertional dyspnea, bipedal edema, chest pain, and cough with chest pain, and maybe or may not be hemoptysis. So bounding pulse, widened pulse pressure, and late diastolic rumbling, that is known as Austin Flint murmur. There are different, so many funny signs are there. So there may be capillary pulsation in the nail bed that become more visible with application of pressure, that is known as Quincke's sign. And pulsatile head bobbing, this is known as Degenerative sign. I say it's correct, Degenerative sign. And visible arterial pulsation in the neck, that is Corrigan sign. Piston should sound on auscultation over the femoral artery, Traube sign, or uvular pulsation, that is known as Muller sign. So these are so many signs are there. Chest excess of aortic dilatation, left ventricle hypertrophy, all these things which are in this echo and this thing. And this after load reduction with S inhibitor on hydrogen, and finally valve replacement therapy. So aortic regurgitation. And mitral valve prolapse. It is important. Mitral valve collapse is not due to rheumatic heart disease. There may be some other causes. There may be symptomatic, or they're associated with palpitation or panic attack. So endocarditis prophylaxis is not required here. So these are the conditions of mitral valve disease. So most important, mitral stenosis with mitral regurgitation, aortic stenosis with aortic regurgitation, and some other condition like mitral valve collapse. So you must remember that the fate of all the mitral valve is heart failure. So heart failure is the ultimate fate of all valvular lesion. Patient comes with heart failure. So how we tackle with the heart failure? This is important. So coming patient with this, कि पेशेंट बोला मेरा पैर में सूजन हो गया, हमको सांस में तकलीफ होता है, हमको दम्मा हो गया. पेशेंट कम्स विथ कि पेशेंट गया पेमोलॉजिस्ट के पास, बोले कि इसको दम्मा हो गया, दम्मा का दवाई चला रहा है लेकिन ठीक नहीं हो रहा, उसको लीवर बढ़ा हुआ है, हो सकता है देयर में भी एसाइटिस आल्सो, ठीक है, देयर में भी जीबीपी. So there are all features of left ventricular failure. So paroxysmal nocturnal dyspnea, liver enlargement, and bilateral basal fine crepitation. This is most important sign of left ventricular failure. So left ventricular failure,
also known as cardiac asthma.
Yes, this is also known as cardiac asthma. So sometimes they ask how we differentiate between asthmatic cardiac asthma and pulmonary asthma or bronchial asthma. So these are very important. Paroxysmal nocturnal dyspnea is very common, and bilateral fine crepitation, pedal edema, hepatic enlargement. Okay, so we come to the congestive cardiac failure. So हार्ट फेलियर जो है एक कॉम्प्लेक्स क्लिनिकल सिम्टम है रिजल्टिंग फ्रॉम स्ट्रक्चरल और फंक्शनल impairment of ventricular filling or ejection of blood, which in turn lead to cardiac or cardinal clinical symptoms of dyspnea and fatigue and signs of heart failure. What are the signs of heart failure? अभी जो मैंने बताया, edema, rales, that is crepitations, become many patients for without sign and volume overload. इस term में heart failure is preferred over the older term for congestive heart failure. So हम लोग अभी heart failure बोलते हैं, congestive नहीं बोलते हैं. So in developed country, coronary heart disease or coronary artery disease is the most common causes of heart failure. Developed country में coronary heart disease most common. But in हमारे राज्य में Africa, Asia, rheumatic heart disease remain the major cause of heart failure. So India में rheumatic heart disease, foreign में coronary artery disease. Now, what is cor pulmonale? This is also a very important topic. Cor pulmonale. It is the right ventricular failure due to chronic lung disease and is triggered by the onset of pulmonary hypertension, also known as pulmonary heart disease. So, cor pulmonale is due to right ventricular failure, secondary to COPD after development of pulmonary hypertension. ठीक? So, what is the most common cause of right heart failure? The most common cause of right heart failure is left heart failure. Left heart failure पहले होगा, वो जाकर के right heart failure कराएगा. So this is important. Left failure का causes देख लिए, and right failure due to left failure. Now, what are the causes of heart failure? What are the causes of heart failure? तो हमने बताया कि एक होता है depressed ejection fraction less than 40%. एक होता है preserved ejection fraction more than 40 to 50%. तो ejection fraction पंप करने का ताकत. So ejection fraction कम किस में होगा? Coronary artery disease जैसे myocardial infarction, myocardial ischemia. Chronic pressure overload. Pressure overload होगा किसमें? Hypertension में होगा. And obstructive valvular disease. Obstruction होगा तो उसको जोर लगाना पड़ेगा, ejection fraction कम होगा. It may lead to heart failure. Third is chronic volume overload. Chronic volume overload like this regurgitation valve disease, intracardiac left to right shunt. Third is chronic lung disease, cor pulmonale or pulmonary vascular disease. So these are the depressed ejection fraction. Now, where ejection fraction preserved, but there is more work of the heart. So pathologic hypertrophy, obstructive cardiomyopathy, hypertension, aging, restrictive cardiomyopathy, other conditions, sarcoidosis वगैरह वगैरह जितना भी है सब इसमें कराता है. ठीक. So there is a condition we know that high output failure. How output failure thyrotoxicosis में होगा? There may be cardiac failure, high output failure thyrotoxicosis. Beriberi में होगा nutritional deficiency, और there may be chronic anemia. हार्ट को ज्यादा पंप करना पड़ता है due to less oxygen or hemoglobin. So these are the causes of right heart failure. Now हमने पहले बताया था कि what are the symptoms, clinical features क्या है. तो नंबर 1, पेशेंट का खून जाएगा कम पेरिफेरी में तो पेशेंट बोलेगा हमको कमजोरी लग रहा, सर हमको बहुत कमजोरी लग रहा, फैटिग. बोला सर हम जब चलते हैं सीढ़ी चढ़ते हैं तो हमको सांस दम फूलने लगता है. सो देयर इज शॉर्टनेस ऑफ ब्रेथ. एक्सर्शनल डिस्निया फर्स्ट एंड लेटर ऑर्थोपनिया, दैट इज ऑर्थोपनिया डिस्निया इन रिकम्बेंट पोजीशन. सो फैटिग, डिस्निया, एक्सर्शनल डिस्निया, ऑर्थोपनिया and paroxysmal nocturnal dyspnea. PND is acute episode of severe dyspnea and coughing that generally occurs at night and awake the patient from sleep, usually 1 to 3 hours after the patient retires. सोने जा रहा है 1-3 घंटा में उसको लगेगा कि हमको इतना सांस फूल रहा कि हमको उठना बैठ के पढ़ना, उठना बैठना, खिड़की के सामने जाके सांस लेता है वो. ये क्रसिकल होता है PND का. तो whereas orthopnea may be relieved by sitting upright, बैठे के हो जाएगा, उठ के बैठेगा तो कुछ आराम होगा. At the side of the bed with leg in a dependent position. Patient with PND often have persistent coughing and wheezing even after they have assumed their upright position. देखो this difference. एक तो है कि bronchial asthma में वो बैठ के सामने खड़ा हो जाएगा, बैठ जाएगा ऐसे करके तकिया लेके तो उसको आराम होगा. But in this case, there may not be relief completely. So it wheezing and this cough persist. So there may be chain of stroke respiration, acute pulmonary edema, increase JVP, there may be crepitation, pulmonary rales मिलेगा, cardiomegaly, hepatomegaly, peripheral edema. So these are the all signs of clinical congestive cardiac failure. Now, what are the investigation? Investigation number one is chest X-ray करेंगे हम लोग, 2D echo करेंगे, most useful index of left ventricular function, जिसमें EF stroke volume divided by end diastolic volume, that is EF. Now, what are the biomarker of CHF? Biomarker क्या है? So, biomarker is very important कि B type natriuretic peptide, B type natriuretic peptide, and terminal PTO BNP, that is anti-BNP, C reactive protein, T and F, troponin T and I. These are the all biomarker of CSF. So most important B type natriuretic peptide. ये चार गो आएगा तो इसमें सबसे लिख लेना पहले कि बी टाइप natriuretic peptide. This is classical increase in case of congestive heart failure. Important. So हम लोग तो देख लिए, हम लोग देख लिए, उसको हम डाइवर्ट करेंगे. अब हाउ यू ट्रीट द पेशेंट? वेरी सिंपल ट्रीटमेंट, कुछ नहीं करना है. उसमें पहले तो करना है कि हमको दो हमको गोल लेना है. एक तो है कि पेशेंट को रिलीव करना सिम्टम से, सो रिलीफ ऑफ कंजेस्टिव और लो आउटपुट सिम्टम एंड रेस्टोरेशन ऑफ कार्डियक परफॉर्मेंस. सो पहले हम लोग क्या देंगे, उसको डायरेटिक्स देंगे. डायरेटिक्स में फ्रूसेमाइड देते हैं और थायजाइड डायरेटिक देंगे. कुछ कार्डियक इनोट्रोपिक देंगे. डिजॉक्सिन पहले बहुत यूज होता था, आजकल डोबुटेनामाइड, एमाइडेरॉल, ये सब हम लोग यूज करते हैं अभी. वेसोडायलेटर देंगे, एस इनहिबिटर, हाइड्रोलाजिन, नाइट्रोप्रोसाइड, और बीटा ब्लॉकर्स में मेटोप्रोलॉल, बिसोप्रोलॉल और कार्बोडिलॉल. इसको हम लोग यूज करते हैं हार्ट फेलियर में. नाउ दूसरा है कि ड्रग्स व्हिच कॉजेस अरेस्ट और रिवर्सल ऑफ द डिजीज प्रोग्रेशन एंड प्रोलॉन्गेशन ऑफ सर्वाइवल इन क्रिएटिव. तो क्या, एस इनहिबिटर, एटी एंटागोनिस्ट, एंजियोटेंसिन रिसेप्टर ब्लॉकर, बीटा ब्लॉकर, एल्डोस्टेरोन एंटागोनिस्ट में स्पाइरोलेक्ट्रॉन हम लोग देते हैं. सो दीज आर देते हैं. सबसे इंपॉर्टेंट है, पूछ देगा कि व्हाट आर द न्यूअर ड्रग्स फॉर हार्ट फेलियर. ये सब तो पुराना ड्रग है. न्यूअर ड्रग में हम क्या देते हैं? तो नंबर वन इवाब्रेडिन. इवाब्रेडिन इज वेरी इंपॉर्टेंट. एंड सेकेंड इज कॉम्बिनेशन ऑफ सेकुबिट्रिल एंड वल्सर्टन. दो इंपॉर्टेंट ड्रग है जो याद रखना, नीट में आ सकता है कि व्हाट आर द न्यूअर ड्रग फॉर दिस एंड व्हाट आर द मैकेनिज्म ऑफ एक्शन ऑफ इवाब्रेडिन. सो इवाब्रेडिन क्या करता है? इट ब्लॉक्स द हाइपर पोलराइजेशन एक्टिवेटेड साइक्लिक न्यूक्लियोटाइड गेटेड, HCN चैनल को ये ब्लॉक करेगा. हाइपर एच से होता है हाइपर पोलराइजेशन एक्टिवेटेड साइक्लिक न्यूक्लियोटाइड गेटेड चैनल. एंड ये क्या करता है एशियन चैनल? इट इज रेस्पॉन्सिबल फॉर द कार्डियक पेसमेकर. फनी चैनल, फनी करंट, FIF, फनी करंट को वो रेगुलेट करता है हार्ट रेट को. सो हम लोग इसको देते हैं इवाब्रेडिन. ये HCN चैनल को ब्लॉक करता है इवाब्रेडिन. दिस इज इंपॉर्टेंट.
तो बोलते हैं फनी सोडियम चैनल ब्लॉकर.
हाँ,
और अपार्ट फ्रॉम बीटा ब्लॉकर्स, इवाब्रेडिन को भी लोग आजकल बहुत यूज कर रहे हैं
बहुत यूज
क्योंकि
करते हैं.
हाँ, साइड इफेक्ट कम है. एक
राइट.
इवाब्रेडिन में साइड इफेक्ट है विजुअल टॉक्सिसिटी, विजुअल इश्यूज रहते हैं, साइड इफेक्ट रहते हैं. इसके
हाँ,
अलावा आप जैसे बता रहे थे सैक्यूबिट्रल और वेलसाटन, इसका कॉम्बिनेशन को यूज
हाँ,
करते हैं आजकल.
हाँ. तो सेक्यूबिटल इज एन एंजियोटेंसिन नेप्रेलाइसिन इनहिबिटर.
नेप्रिलाइसिन इनहिबिटर.
है ना?
नेप्रिलाइसिन को न्यूरो एंडोपेप्टिडेज भी बोलते हैं.
हाँ, तो वो उसको होता है आर्नी, ARNI,
हम्म.
एंजियोटेंसिन रिसेप्टर नेप्रिलाइसिन इनहिबिटर.
हाँ.
आर्नी, ARNI, ए से हो गया एंजियोटेंसिन, आर से हो गया रिसेप्टर, एन से हो गया नेप्रिलाइसिन, आई से इनहिबिटर.
इनहिबिटर.
ये आर्नी बोल के भी आता है. सो
हाँ.
आर्नी को ही करता है. और भल्साटन तो क्या है? भल्साटन इज जस्ट ARB है.
हम्म.
दैट इज ARB.
हाँ.
एंजियोटेंसिन रिसेप्टर ब्लॉकर, है ना?
हाँ. हाँ.
तो दोनों हम लोग इसमें यूज करते हैं. तो दो तो इंपॉर्टेंट है, इवाब्रेडिन एंड कॉम्बिनेशन ऑफ सल्बिट्रल वेलसर्टन.
हम्म.
ये इंपॉर्टेंट है. ठीक है.
हाँ. हाँ.
तो
और भी
हार्ट
बहुत
फेलियर
सारे
का ही.
ड्रग्स आए हैं, लिवोसिमेंडन,
हाँ.
बहुत सारा
हाँ तो
दवाई है.
हाँ तो नए नए ड्रग जितना भी आया, लेकिन अभी करंटली सब हम लोग यूज करते हैं. बाकी न्यूअर ड्रग जो यूज होता है तो उसको देख लेना. ठीक है. सो दीज आर द हार्ट दिस ये
congestive cardiac failure.
valvular degeneration with rheumatic, congestive cardiac failure. ठीक है?
Right.